Welcome to the Deep Dive, the show that extracts the most essential knowledge from the most complicated topics.
Today, we are diving deep into the body's command center, the endocrine system.
Yeah, these are the master controllers, using hormones as their communication tools.
Right. We're talking about the glands that manage, well, everything. How fast you metabolize energy, how much water your body holds onto, how you manage stress.
The pituitary, thyroid, parathyroid, adrenals, and the pancreas.
All of them.
And our mission today is really focused on what happens when these systems fail. The endocrine system relies on these really complex feedback loops, and when they break, the resulting condition is defined by either, a dramatic hormonal excess, what we're calling the hyper state.
Or debilitating deficiency, the hypo state.
Exactly. So we're going to compare and contrast these polar opposites across 5 major systems.
The goal is to give you the key assessment findings and the critical management strategies that honestly make all the difference.
It's a study in extremes.
It really is.
Yeah.
And we're going to start right at the top with the pituitary, often called the master gland.
Okay.
Specifically the posterior portion, which controls our fluid balance via antidiuretic hormone, or ADH. You'll also hear it called vasopressin.
So let's unpack this water system first. When the pituitary malfunctions, we get 2 completely opposite conditions affecting hydration.
SIADH and diabetes insipidus.
Let's start with SIADH, syndrome of inappropriate ADH. This is the excessive or hyperfunction state.
This is where the body is just.
Yeah.
It's flooded with too much ADH. The hormone is basically screaming at the kidneys, keep every single drop of water.
And that excessive water retention leads to a state of water intoxication.
Cellular edema, yeah.
But the key consequence here isn't just the volume overload, right? It's a really dangerous electrolyte imbalance.
It is.
So why does retaining water cause the body to get rid of sodium? It seems counterintuitive.
It's a critical mechanism, and it's a great question. The excess water retained dramatically increases the overall volume of fluid in the circulation. The body's volume receptors, they recognize this huge increase in volume, and this actually suppresses the renin-angiotensin-aldosterone system, or RAAS.
So the body's trying to fix it.
It's trying to fix it, yeah.
Yeah.
The goal of suppressing RAAS is normally to decrease volume by peeing out sodium and water. But here's the catch.
The ADH is still there?
The ADH is still forcing water retention, so the net effect is just aggressive renal sodium excretion. You're holding onto water and dumping salt.
So the body senses fluid overload, tries to fix it by dumping salt, even though the primary problem is too much water. And the result is what we call dilutional hyponatremia.
Precisely. The serum is diluted, and water, it moves from the lower concentration area of the plasma into the cells, causing them to swell.
Which is why they don't get that classic pitting edema you see in other fluid overload states.
Exactly. The water is evenly distributed into the intracellular space, and this swelling, particularly in the brain cells, is what presents the major neurological danger.
Let's talk about the causes. You mentioned that the secretion is often inappropriate, meaning it's bypassing the normal feedback loops.
Yes, often because the hormone is being produced by cells that just shouldn't be producing it.
Like a tumor.
Malignant tumors are primary offenders. Small cell lung cancer is notorious for producing ADH ectopically so, outside of the pituitary.
What else?
Other causes include primary brain injuries like meningitis, a stroke, or subarachnoid hemorrhage. Also pulmonary infections like pneumonia or even common medications.
Oh, really? Which ones?
Things like SSRIs, carbamazepine, and certain chemotherapy agents.
So if you know the pathophysiology, the patient assessment in labs should, I imagine, clearly show this contrast between concentrated and dilute.
Absolutely. Clinically, they show signs of fluid volume excess. You might hear crackles in the lungs, they'll have elevated blood pressure, weight gain.
But without the obvious edema.
Right. And when we look at the labs, everything in the urine is concentrated.
Okay.
Urine osmolality is very high, often over 1200, and the specific gravity is high, exceeding 1.032.
And the blood is just the mirror image of that.
The blood is dilute. Low serum osmolality, less than 275, and most dangerously, hyponatremia sodium below 135.
And this is where the critical neurological risk comes.
Yes. If that sodium level drops into the range of 116 to 125, you start seeing personality changes, confusion.
And below that?
Below 116, the risk of seizures, coma, and death just skyrockets because of that severe cerebral edema.
So when you're treating this, if the core problem is excess water, the solution has to be a strict, uncompromising fluid restriction.
That is the primary treatment, fluid limitation. usually constrained to a tiny amount, maybe 800 milliliters to 1 liter total per day.
That's a huge challenge for patients that must be incredibly thirsty.
They are, and it means counting everything, ice chips, hidden sources in food, everything. Compliance is absolutely critical.
Okay, so what if the sodium needs correcting because it's dangerously low? You mentioned using hypertonic saline, but you also said that correcting it too fast is dangerous. Why is the speed of correction so crucial?
Because of the risk of cerebral osmotic demyelination syndrome, or CODS.
Right.
You see, when the brain cells swell due to the hyponatremia, they adapt by reducing their own intracellular osmoles.
Okay, they're trying to find a new balance.
Exactly. But if we correct the sodium in the blood too quickly, the surrounding serum becomes hypertonic relative to those adapted brain cells, and it just yanks water out of them.
Because they shrink too fast.
Far too fast. This osmotic shift damages the protective myelin sheath covering the nerves. And the consequences, paralysis, pseudobulbar palsy, locked-in syndrome, they're permanent and devastating.
It's a tightrope walk. You're balancing the immediate seizure risk of low sodium against the permanent damage risk of rapid correction.
It's one of the most delicate balances in critical care.
And that makes the nursing detail you mentioned about tube feeding even more critical. You said never flush those tubes with plain water.
Never. Because water is hypotonic, it immediately compounds the dilution problem. You must flush with normal saline, which is isotonic, to maintain that sodium balance and avoid further diluting the blood. We also use medications like dimeclocycline, which is remarkable because it actually makes the kidney tubules resistant to the effects of ADH.
Fascinating. Now let's flip the switch and look at diabetes insipidus. This is the devastating a severe lack of ADH effect.
DI is the complete opposite of SIADH. It's just excessive, unmitigated water loss.
So whether it's neurogenic DI, where the pituitary fails to secrete ADH,
Or nephrogenic DI, where the kidneys fail to respond to it.
the result is the same.
Extreme polyuria, severe dehydration, and critical hypernatremia.
You're talking about 4 to 30 liters of urine output a day. That is a truly staggering volume loss. It threatens immediate cardiovascular collapse.
It's catastrophic. A person can lose a third of their total body water in a single day. The hypernatremia is a direct consequence of the body losing pure water much faster than it loses salt.
So the blood just gets thicker and thicker.
It concentrates very, very quickly.
The causes are interesting, too. For neurogenic DI, it's brain damage, head trauma, surgery near the pituitary, tumors.
Yeah.
But for nephrogenic DI, where the kidney is resistant, we noted that dimeclocycline, the drug used to treat SIADH, can actually cause DI.
It illustrates the powerful and sometimes unpredictable nature of these hormones.
Right.
We use dimeclocycline to induce kidney resistance in SIADH, but if we overuse it or if a patient is susceptible, that resistance can become full-blown nephrogenic DI. Lithium is another major drug cause.
So assessment here is all focused on severe dehydration. What are the key lab findings that confirm this?
Well, SIADH had concentrated urine and dilute serum.
DI is the opposite.
DI has dilute urine and concentrated serum. Urine-specific gravity is extremely low, below 1.005, and osmolality is low, often less than 300.
And the serum?
The serum is screaming concentrated.
Yeah.
Serum sodium greater than 145, serum osmolality greater than 303.
In that concentrated blood is what causes the neurological signs.
Yes, this thick hypertonic blood pulls water out of the brain cells, causing neurological signs like ataxia, confusion, and potential seizures.
So management has to focus entirely on replacing that lost volume and then replacing the missing hormone.
Volume replacement is urgent. Oral intake is preferred, but it's often impossible given the rapid rate of loss.
So you start an IV.
We administer IV hypotonic solutions like D5W to slowly dilute the concentrated blood without causing massive cerebral edema.
And for neurogenic DI, the treatment is desmopressin.
Desmopressin is synthetic vasopressin. It can be given orally, subcutaneously, or nasally. The crucial nursing task is titrating that dose.
How do you know if it's working?
We administer the drug, and then we monitor the patient's urine output and specific gravity. If the urine output dramatically decreases and the specific gravity increases, we know the dose is effective.
And if it's too much?
If the patient starts showing signs of water retention and low sodium, essentially inducing a state of SIADH, we know the dose is too high.
The hourly monitoring here must just be relentless. You can't just set an IV drip and walk away.
You absolutely cannot. We monitor intake and output hourly. The critical instruction for the nurse is to ensure fluid intake exceeds urine output to catch up with the deficit.
So you're constantly adjusting.
We adjust hourly. If the patient loses 500 milliliters in the past hour, they need more than 500 milliliters in the next hour to prevent that spiral into shock. We're watching daily weights and immediately reporting any weight loss or rising sodium levels.
Wow. Okay, we've covered fluid balance. Let's shift our focus to the thyroid gland, which is like the body's accelerator pedal.
That's a great way to put it. It controls the basal metabolic rate, or BMR.
And here again, we see the same hyper versus hypo contrast, but this time controlling speed and energy.
That's right. Every single cell in the body is affected by thyroid hormone. Too much, and the patient is running a continuous marathon.
And too little.
They're moving through molasses.
So let's start with hyperthyroidism, the ultimate hypermetabolic state. The most common cause is Graves' disease, an autoimmune condition.
Graves is fascinating. It's an autoimmune process where the body produces these things called thyroid-stimulating immunoglobulins, or TSI antibodies.
Okay.
And these antibodies, they mimic the TSH produced by the pituitary, so they're constantly stimulating the thyroid gland to produce excessive T3 and T4.
Which leads to that increased BMR, heat production, and cardiovascular function.
All of it.
The patient presentation sounds absolutely exhausting. Hyperactivity, nervousness, severe weight loss despite an increased appetite.
And profound heat intolerance. They're always hot.
Right.
The two classic physical signs are the enlarged thyroid, the goiter, and this very distinct visual manifestation, exophthalmos.
Which is the forward protrusion of the eyeballs.
Yes, the immune reaction causes the orbital tissue behind the eye to swell, pushing the eyeball forward.
And exophthalmos isn't just cosmetic, is it? It carries some severe clinical risks.
Oh, it creates a major risk for corneal damage.
Yeah.
The eyelids can't close completely, which leads to dry eye, irritation, and potential ulceration.
So how do you manage that?
Management includes things like artificial tears, eye shields at night, and critically, elevating the head of the bed while sleeping to encourage fluid drainage from that orbital area to reduce the swelling.
Now let us turn to the life-threatening emergency here. Thyroid crisis or thyroid storm. This is a massive sudden surge of T3 and T4.
A thyroid storm means the body is completely redlining.
Total overload.
It's often triggered by a major stressor, an infection, thyroid surgery, or trauma, in an already hyperthyroid patient. The manifestations are extreme. Uncontrolled hyperthermia, with temperature spiking above 102 degrees Fahrenheit.
Wow.
Severe tachycardia, often reaching 180 to 200 beats per minute, and a profound neurological crash. Psychosis, agitation, delirium, and often seizures.
So since this is a massive physiological overload, the treatment has to be rapid stabilization before you can even think about blocking the hormones.
You must start with symptomatic control immediately. First, cooling measures.
Not aspirin, though.
No aspirin, that's a key point. It can interfere with thyroid hormone binding. But cooling blankets and acetaminophen are vital.
Okay, what's next?
Second, fluid, glucose, and electrolyte replacement because of that hypermetabolic state. And third, cardiovascular stabilization, often using beta blockers like propranolol.
And that does more than just slow the heart rate, right?
It does. It not only controls the heart rate, but it also blocks the peripheral conversion of T4 to the more active T3 hormone.
And the actual anti-thyroid medications, they take too long to prevent the immediate crisis. Is that right?
Exactly. Drugs like methimazole and propylthiouracil, or PTU, they block new hormone synthesis, but they don't affect the massive stores of hormone that are already circulating in the blood.
So stabilization first.
Stabilization is the absolute priority, as the pharmacological treatment only starts working weeks later.
For long-term treatment, you have a couple of options: chemical ablation using radioactive iodine or surgical removal. Let's delve into the specific precautions for radioactive iodine I-131.
I-131 is highly effective because the thyroid gland uniquely absorbs iodine. The substance gets taken up and then destroys thyroid cells over weeks, ideally leading to a hypostate that is much more easily managed.
But because it's a radiation source, there are specific patient education points that are vital to protect others.
Absolutely.
So tell us about those radiation risks.
The patient has to treat all of their bodily fluids as potentially radioactive for several days.
Okay.
They need to use a private toilet and flush it 2 or 3 times after each use. They should drink plenty of fluids to help clear the iodine faster. Use disposable utensils if possible.
And avoid close contact.
Avoid close contact or preparing food for family members, especially children or pregnant women. The goal is just to minimize radiation exposure to everyone around them.
Okay, and if they opt for a thyroidectomy, what preparation is necessary to make that surgery safe?
Well, the thyroid is a highly vascular organ.
Right, it bleeds a lot.
It does. So preoperatively, The patient must be given antithyroid medications and iodine preparations, like potassium iodide, to decrease the vascularity and the size of the gland.
And that minimizes the hemorrhage risk during the surgery itself.
Exactly. We also teach them neck support techniques, like supporting their head with both hands when they move, to prevent strain on the incision site after the operation.
Post-surgery, the risk is twofold: hemorrhage and airway, and then the parathyroid complication.
Airway obstruction due to hemorrhage or laryngeal edema is the absolute priority, especially in the first 24 hours.
So what are you looking for?
We position them in semi-Fowlers and monitor very closely for stridor, which is that harsh, high-pitched breathing sound. It indicates immediate airway narrowing.
And you have to be ready to intervene.
The tracheostomy tray and suction must be immediately available at the bedside.
And the hormonal danger.
Inadvertent removal or damage to the parathyroid glands. Since these 4 tiny glands sit right next to the thyroid, they are very easily damaged,
And that leads to immediate hypocalcemia.
which manifests as tetany. We must have IV calcium gluconate or chloride readily available at the bedside to treat severe symptomatic hypocalcemia immediately. It is a top priority.
Shifting to hypothyroidism now, the slowed state, where the body lacks those energy accelerator hormones.
This results in a drastically decreased BMR and heat production. Primary hypothyroidism, often due to Hashimoto's disease, which is an autoimmune condition that destroys the thyroid tissue, is the most common cause.
The manifestations sound like a generalized systemic slowing. They could almost be mistaken for simple aging or depression.
They do, and they often are. We see profound lethargy, diminished deep tendon reflexes, weight gain despite a poor appetite, severe cold intolerance, and chronic constipation because the GI tract is slowed way down.
And there are classic physical signs.
Yes, coarse, dry hair and skin, a deep, raspy voice, and non-pitting edema, known as mixed edema, particularly around the eyes. That's periorbital edema, and the extremities.
And the lab values here are the exact inverse of hyperthyroidism.
For primary hypothyroidism, yes. T4 and free T4 are decreased, and TSH is increased. The pituitary is screaming at a thyroid that just isn't responding.
And the emergency here is myxedema coma.
This is a devastating failure of metabolism, usually precipitated by an infection, cold exposure, or just failing to take replacement medication. The body just shuts down.
What does that look like?
Patients experience severe hypothermia, with body temperatures dangerously low, profound metabolic derangements, hyponatremia, hypoglycemia, lactic acidosis, cardiovascular collapse, and that non-pitting myxedema.
It sounds incredibly severe.
It is. It requires aggressive warming, ventilation support, and immediate IV thyroid hormone replacement.
So management relies entirely on lifelong medication, levothyroxine. This drug requires really strict adherence and careful monitoring.
Levothyroxine must be taken lifelong at the same time every morning and on an empty stomach.
An hour before breakfast, right?
Ideally, yes, an hour before breakfast, because various foods and supplements like calcium or iron can interfere with its absorption.
And there's a critical safety instruction.
You have to hold the dose and call the provider if the patient's heart rate exceeds 100 beats per minute, or if they experience tremors or anxiety.
Because that means the dose is too high.
It indicates the dose is too high and it's pushing them into a dangerous artificial hyperthyroid state.
So the dose needs to be managed carefully, providing just enough speed to normalize their function without causing tachycardia.
Exactly. Nursing care focuses on comfort, providing warmth and blankets, and managing that common issue of constipation by encouraging a high-fiber diet and at least 2,000 milliliters of water daily.
Okay. We've seen how interconnected these systems are, especially in the neck. Let's move specifically to those 4 tiny parathyroid glands, which are the absolute masters of 2 other vital electrolytes, calcium and phosphate.
Right, these glands release parathyroid hormone, or PTH, which is the body's primary tool for increasing serum calcium when it's low.
So if PTH is high, calcium is high.
And if PTH is low, calcium is low. And they have an inverse relationship with phosphate.
So starting with hyperparathyroidism, that's the start of excessive PTH secretion, leading to hypercalcemia.
Right. High PTH pulls calcium out of 3 places: the bones, the gut via vitamin D activation, and the kidneys.
The result is dangerously high serum calcium
and correspondingly low serum phosphate.
The classic clinical consequences of hypercalcemia are often summed up in that mnemonic: stones, bones, abdominal groans, and psychic moans.
That's a perfect summary. The stones are the excess calcium deposits leading to renal calculi, causing polyuria in kidney stones.
The bones.
The bones are the decalcification process. PTH is dissolving bone, leading to pathological fractures, bone pain, and osteoporosis.
Groans are GI issues.
Severe constipation, anorexia, abdominal pain, and the moans are the neurological and psychological effects: fatigue, depression, confusion.
Management really depends on the severity. If it's mild, what's the intervention?
We aim to dilute the calcium and reduce bone breakdown. So for mild cases, aggressive hydration 2,000 to 3,000 milliliters of fluid daily is crucial to flush the kidneys and prevent stone formation.
And exercise is important.
Weight-bearing exercise is surprisingly important, yeah. Physical stress helps push calcium back into the bones. And of course, patients must strictly avoid calcium and vitamin D supplements.
And for an acute hypercalcemic crisis where the calcium levels are dangerous,
We need to decrease serum calcium quickly. This involves high-volume IV, normal saline, and loop diuretics to promote rapid renal excretion.
and medications.
We use medications like bisphosphonates, such as pamidronate. They are powerful agents that inhibit osteoclast activity, effectively locking the calcium into the bone.
So it stops the resorption.
Exactly. Calcitonin is another option, as it directly opposes PTH action.
And the nursing focus remains on safety because of how fragile the patient's skeleton is.
Absolutely. Fall prevention is vital. We also need to be vigilant for signs of kidney stones, so we strain all urine and monitor INO.
Now for the opposite state. Hypoparathyroidism resulting in hypocalcemia. You mentioned this is often iatrogenic, caused by surgical damage during a thyroidectomy.
Yes. Low PTH leads to low serum calcium and consequently high serum phosphate. The danger here is immediate and relates entirely to neuromuscular function.
So if hypercalcemia slows the nervous system down, hypocalcemia makes it hyperexcitable. Why does low calcium lower the threshold for nerve excitability?
Calcium acts as a stabilizer for the nerve cell membrane.
Okay.
When calcium levels drop, that membrane becomes overly permeable to sodium, which makes the nerve fire much more easily and frequently. This manifests as profound neuromuscular irritability.
What are the first signs a patient usually reports?
Usually anxiety, headaches, and the hallmark symptom is paresthesia, numbness, and tingling, often starting around the mouth, lips, fingertips, and extremities.
And as it progresses?
It progresses to muscle spasms, severe cramping, and the life-threatening condition of tetany or seizures.
And the classic physical assessment signs, Schwastek and Trousseau.
These are essential bedside assessments. The Schwastek sign is a twitching of the facial muscles when you tap the facial nerve just in front of the ear.
Then Trousseau.
The Trousseau sign is a carpal spasm, a painful flexing of the wrist and fingers, which you can induce by inflating a blood pressure cuff above the systolic pressure for a few minutes.
And if you see those, you know you're dealing with hypocalcemia.
Both are a definitive confirmation of latent tetany due to hypocalcemia.
Since this can progress to immediate tetany, management requires fast calcium replacement.
Acute symptomatic hypocalcemia requires immediate IV calcium replacement, typically calcium gluconate.
In long term.
Long-term management involves oral calcium supplements and high-dose vitamin D because vitamin D is absolutely necessary for the intestinal absorption of calcium. We also educate the patient on maintaining a high calcium, high vitamin D diet.
We've covered the fluid controllers, the speed regulators, and the electrolyte balancers. Now we move to the adrenal glands, which sit atop the kidneys, controlling our stress response, and steroids.
Right.
And this system, specifically the adrenal cortex, is defined by the massive opposing conditions of Cushing's and Addison's.
The adrenal cortex primarily manages glucocorticoids like cortisol and mineralocorticoids like aldosterone. Cortisol is our primary stress hormone. Aldosterone manages sodium and potassium balance.
Let's start with Cushing's syndrome. This is the state of chronic hypercortisolism, too much steroid exposure. What is the most common cause we see in clinical practice?
The vast majority of cases are iatrogenic.
So caused by medical treatment.
Exactly.
Of course.
Specifically, long-term, high-dose use of prescribed glucocorticoids for chronic inflammatory conditions like severe asthma, autoimmune disorders, or organ transplants.
So the treatment for one condition inadvertently causes the hyperfunction of the adrenal axis.
Right. Other causes can be a pituitary tumor, which is actually Cushing's disease leading to excessive ACTH, or an adrenal tumor producing cortisol independently.
And elevated cortisol has devastating systemic effects because it's catabolic. It breaks things down.
It does, and the physical findings are immediately recognizable and highly distressing to the patient.
They're classic.
Abnormal fat deposition resulting in truncal obesity, thin extremities from muscle wasting, a fatty pad on the upper back called a buffalo hump.
And the characteristic moon facies.
The round, puffy face, yes. Cortisol also thins the skin, leading to easy bruising and wide, purple striae on the abdomen and thighs, poor wound healing, and osteoporosis.
Cortisol also affects electrolytes and glucose, confirming that hyperstate in the labs.
Labs will show elevated sodium, elevated glucose, often causing a secondary diabetes and hypokalemia. Patients also suffer from immune suppression and emotional lability, everything from euphoria to severe depression.
Treatment depends on the cause, like tumor removal or radiation. But the management of the steroids themselves requires a critical, gradual approach.
Yes, if the cause is a tumor and we remove it, or if the patient is on prescribed steroids, you cannot stop them abruptly.
Why not?
Because the constant high level of exogenous cortisol suppresses the body's natural ACTH and cortisol production through the negative feedback loop. If we stop cold turkey, the natural system won't kick back in quickly enough.
And you get a massive immediate drop in both cortisol and aldosterone.
Right, and that sounds like a direct trigger for the opposing crisis state.
It is. The gradual withdrawal is the primary preventative measure against an Addisonian crisis.
For inoperable cases, we can use medications like metirapone or midotane, which directly suppress cortisol synthesis and secretion. Nursing care really involves safety due to severe osteoporosis and pathological fracture risk, and strict infection control because of the immune suppression.
Now to the devastating hypostate, primary Addison's disease or adrenocortical insufficiency.
This is a lack of both primary adrenal hormones cortisol and aldosterone, usually due to autoimmune destruction of the adrenal cortex. The body just lacks the tools to manage stress and fluid volume.
What are the consequences of missing aldosterone?
Aldosterone is the key to retaining sodium in water while excreting potassium. So without it, the patient suffers severe fluid and volume loss, leading to hyponatremia and hyperkalemia.
And without cortisol,
they become hypoglycemic and cannot respond to even minor physical stress.
The assessment findings are the complete inverse of Cushing's, except for one highly distinctive visual feature.
The most famous sign is hyperpigmentation, a darkening of the skin, especially in sun-exposed areas, creases, and mucous membranes.
Why does that happen?
It happens because the pituitary tries desperately to stimulate the failing adrenals by increasing ACTH. And ACTH shares a precursor molecule with melanocyte-stimulating hormone, or MSH. So the high ACTH causes melanocytes to overproduce pigment.
Clinically, they present with profound weakness, severe weight loss, uncontrollable GI distress,
and severe life-threatening hypotension due to that volume loss. The hypotension is the greatest immediate threat. This condition leaves the patient perpetually on the edge of cardiovascular collapse.
And when that collapse occurs due to stress, infection, or sudden steroid withdrawal, we enter the Addisonian crisis.
This is a medical emergency. It's characterized by high fever, excruciating penetrating pain in the abdomen, lower back and legs, intractable vomiting and diarrhea, and severe shock leading to coma.
How do you treat this immediate collapse? It has to be rapid replacement and volume resuscitation.
Rapid infusion of high-volume 5E fluids, usually normal saline, to correct the volume deficit and hypotension. Then, immediate high-dose hormone replacement.
Both hormones?
Both a mineralocorticoid, like fludrocortisone, to retain sodium and water, and a glucocorticoid, like hydrocortisone, to restore the stress response.
Since this is a lifelong condition, what is the critical patient education required?
Lifelong compliance is non-negotiable. They must wear a medical alert bracelet. They must carry an emergency kit with injectable intramuscular cortisol that they can self-administer during any period of severe stress, vomiting, or infection before they can get medical help.
And their diet?
They also need a diet that includes adequate sodium and is low in potassium to compensate for the missing aldosterone effect.
Okay, before leaving the adrenals, we have to touch on the medulla, the center for fight or flight. There is a rare but intensely dangerous tumor here called a pheochromocytoma.
Yes. This tumor causes the massive uncontrolled release of catecholamines, epinephrine, and norepinephrine.
So it's like being shot up with a continuous, uncontrolled dose of adrenaline.
The patient is in constant, overwhelming sympathetic stimulation. The most dangerous result is rapid malignant hypertension.
How high are we talking?
We're talking systolic blood pressures easily spiking to 250 or 300 mmHg, leading to stroke, myocardial infarction, or visual changes and headaches.
Management focuses on controlling that acute sympathetic surge while preparing for surgical removal.
Surgical adrenalectomy is the cure, but the patient must be stabilized first. We use alpha-adrenergic blockers first, like prazosin or phenoxybenzamine, to control the blood pressure and prevent unopposed vasoconstriction before surgery.
Wait, why is the sequence of blockers so critical? Why alpha before beta?
Great question. Because if you administer a beta blocker first, You block the vasodilatory effects of beta receptors in the blood vessels, leaving the potent vasoconstricting effects of the alpha receptors unopposed.
Which would cause an even bigger spike in blood pressure.
It can cause a massive catastrophic hypertensive crisis that is often fatal. You must control the vasoconstriction first. We also use a drug called metarocine to suppress the synthesis of the catecholamines themselves.
We've examined the central control glands. Now we move to the pancreas and the most common complex metabolic challenge globally, diabetes mellitus.
Right.
This is where insulin, or the lack of it, defines the patient's entire metabolic existence.
Diabetes mellitus is characterized by hyperglycemia due to problems with insulin production, insulin action, or both. It is chronic, systemic, and the leading cause of renal failure, adult blindness, and non-traumatic limb amputation.
Let's quickly distinguish type 1 from type 2.
Type 1 is defined by an absolute lack of insulin due to the autoimmune destruction of the pancreatic beta cells.
So the body just doesn't make any?
None. It usually presents rapidly in childhood or adolescence and requires exogenous insulin for survival. The classic presentation is polyuria, polydipsia, polyphagia, and often weight loss.
And type 2, which is the much more common form, is a condition of compromise and resistance.
Yes. Type 2 starts with peripheral insulin resistance. The cells stop listening to the insulin, and a gradual failure of the beta cells to produce enough insulin to overcome that resistance. It's often related to obesity and age.
But they still produce some insulin.
They still produce some insulin, which is a key distinction we'll see later in the acute crises.
Diagnostics rely on the A1C test, which provides a long-term picture of glucose control.
Yes. The glycosylated hemoglobin, or A1C, reflects the average blood sugar over the preceding 2 to 3 months. An A1C of 6.5% or higher is diagnostic. It's a vital tool because it shows adherence to the plan and gives a more honest assessment than a single, easily manipulated fasting blood glucose test.
Management is a triad of diet, exercise, and medication. Focusing on diet, what are the core principles?
Diet is highly individualized, but the focus is on maintaining blood glucose control. This means complex carbohydrates, moderate protein, and low saturated fats.
And alcohol.
We strongly caution against alcohol consumption. If it's consumed at all, it must be with or shortly after a meal, because alcohol actively suppresses gluconeogenesis in the liver, increasing the risk of severe hypoglycemia.
And exercise is vital because it increases insulin sensitivity.
Exercise at least 150 minutes per week is essentially free medication. It facilitates glucose uptake by muscles, reducing the body's reliance on insulin.
But there is a critical safety warning.
Yes. Exercise must be avoided when diabetes is uncontrolled, specifically when blood glucose is over 250 milli-GDL and ketones are present in the urine.
Why is exercising during a hyperglycemic and ketotic state so dangerous?
Because exercise, which is a physical stressor, releases counter-regulatory hormones like epinephrine and cortisol.
And those raise blood sugar.
They do. They actually increase hepatic glucose production, leading to even higher blood glucose and exacerbating ketogenesis. It accelerates the patient toward DKA. We also have to monitor blood sugar for up to 24 hours after a significant exercise session due to the risk of delayed hypoglycemia as muscles continue to replenish their glycogen stores.
For type 2 patients, oral medications are the first line of defense.
These medications work in different ways. Sulfonylureas, for example, stimulate the beta cells to produce more insulin. The biguanides, like metformin, primarily reduce glucose production by the liver.
Metformin is very common.
Highly effective, but it comes with a risk of lactic acidosis, especially in patients with existing renal impairment.
For type 1, and eventually for many type 2 patients, insulin therapy is required. Let's recap the 4 main types.
We classify them by onset and duration. Rapid-acting, like Lispro, works in 5 to 15 minutes, used for meal coverage. Short-acting, which is regular insulin, works in 30 minutes.
And that's the one that can be given IV.
It's the only type that can be administered intravenously, which is essential in crisis management. Then you have intermediate-acting, NPH, for basal coverage, and long-acting, like Glargine or Detamir, which provides 18 to 24 hours of steady background coverage with no peak.
We need to stress the specific administration instructions.
Yes. When mixing insulins, always draw the regular or clear insulin first, then the NPH, which is cloudy.
Clear before cloudy.
Always. And never shake NPH. Just gently roll the vial. Crucially, rotate injection sites to prevent lipotrophy pitting or hardening of fat tissue, which severely impairs insulin absorption.
And don't inject into a limb you're about to exercise?
Never. The increased blood flow will cause rapid premature absorption and increase the risk of hypoglycemia.
And when low blood sugar hits hypoglycemia, defined as below 70 milli-DDL, we apply the 15-gram rule.
The 15-gram rule is the immediate intervention for mild symptoms like shakiness, hunger, anxiety.
What do you do?
The patient consumes 15 grams of simple carbohydrates like 4 ounces of juice, 8 ounces of skim milk, or 3 to 4 glucose tabs, and then waits 15 minutes to recheck their blood sugar.
And if it's still low?
Repeat the process. We use simple carbs because they are absorbed fastest. If the patient is unconscious, we administer IM glucagon or IVD-50.
Okay, finally, let's contrast the two major life-threatening hyperglycemic crises, diabetic ketoacidosis, DKA, and hyperosmolar hyperglycemic state, HHS.
Right. And these really define the essential difference between type 1 and type 2 diabetes.
DKA is almost exclusively a crisis of type 1 patients who have zero insulin supply.
And HHS is primarily a crisis of type 2 patients who still produce some insulin.
So let's start with the central difference, ketones and acidosis.
In DKA, because there is no insulin, the body can't use glucose, so it resorts to burning fat for energy. This fat metabolism produces acidic byproducts called ketones, leading rapidly to metabolic acidosis, where the pH is less than 7.35.
But in HHS?
In HHS, the type 2 patient still has enough circulating insulin, even if they're resistant to it, to suppress that fat breakdown process.
So they have severe hyperglycemia, but no ketones and no acidosis.
Generally, yes. The DKA glucose is usually greater than 250, but the HHS glucose is often profoundly high, greater than 600, sometimes topping 1,000 milli-DL.
The difference is the pathophysiology.
DKA is a crisis of lack of insulin leading to acidosis. HHS is a crisis of severe hyperglycemia leading to profound dehydration and hyperosmolarity.
And the clinical signs reflect that underlying pathology.
DKA patients, because of the acidosis, display specific compensating symptoms: a fruity or acetone odor to the breath from the ketones.
And small respirations.
To small respirations, yes. Deep, rapid, but non-labored breathing as the body tries to breathe off CO2 to raise the pH. DKA onset is rapid.
And HHS?
HHS onset is gradual, often over days or weeks. Patients present with profound altered level of consciousness, hyperthermia, and extreme neurological findings, including a positive Babinski sign because their blood is incredibly thick and hyperosmolar.
The treatment for both relies heavily on addressing the massive fluid deficit and the electrolyte shifts.
Both crises cause severe dehydration due to osmotic diuresis. The high sugar just pulls water out. The initial treatment is rapid, high-volume fluid replacement, usually normal saline. We often infuse several liters in the first few hours.
When do you switch the fluids?
We switch the fluids to D-Phi-12-NS, a solution with dextrose, when the blood glucose drops to around 250 to 300.
Why is that so important?
Because the primary goal shifts from correcting hyperglycemia to preventing a rapid glucose drop. If glucose drops too fast, the brain can't adjust its osmolarity quickly enough, and you risk cerebral edema.
And the insulin administration.
The regular insulin infusion is started once fluid replacement is underway. We also monitor potassium religiously.
Because insulin drives potassium into the cells.
It does. If the patient is already hypokalemic upon arrival, which often happens because of the severe polyuria, giving insulin without concurrent potassium replacement can induce dangerous hypokalemia, risking fatal cardiac arrhythmias.
So the ultimate preventative measure for all diabetic patients is adhering to the sick day rules.
These rules are life-saving. When you're sick, the body naturally releases counter-regulatory hormones that increase blood glucose, even if you're not eating.
So you have to keep taking your insulin.
You must continue your insulin or medication, monitor blood glucose and urine ketones every 2 to 4 hours, and aggressively hydrate with calorie-free liquids, at least 1 glass every hour, to prevent the dehydration that accelerates these crises.
And you report high numbers immediately.
Report blood glucose above 250 or any ketones in the urine immediately.
What an incredible deep dive into the delicate but powerful balance of the endocrine system. We have seen that these disorders are ultimately defined by a single question. Is there too much or too little of the controlling hormone?
And that the symptoms, assessment findings, and life-saving management strategies are often precise mirror images of each other. The consistency of these opposing hyper and hypo states is what helps organize this massive amount of clinical information.
Right. From the risk of seizures due to brain swelling and SIADH to the risk of cardiovascular collapse in DI or Addison's, the theme is consistent.
The necessity of careful monitoring INO, weight, key electrolytes, and rigorous patient education to prevent those massive life-threatening crises.
And we've also noted that the treatment of one condition, whether it's pharmaceutical or surgical, can inadvertently trigger the opposing condition in an adjacent system.
Which just highlights the total interconnectedness of the human body.
So let's leave you with this provocative thought for the learner, connecting multiple concepts we discussed today. We know the pituitary is the master gland, controlling the thyroid, the adrenals, and even ADH function. Let's imagine a patient with Cushing's syndrome, caused by a pituitary tumor, who undergoes a hypophysectomy, the surgical removal of the pituitary gland to stop the hypersecretion of ACTH.
The goal is to cure the Cushing's, the hyperstate.
Exactly. But since the pituitary no longer controls the downstream glands, what assumptions must we make immediately about this patient's thyroid and adrenal function post-surgery? And what new life-threatening hypostate risk do they suddenly face that we must manage right away, even though we were just treating a hyperstate? Think about what the master gland controlled and what happens when that control is suddenly completely removed.